Yeah, Rien is the CEO of Firely. He's a guy that dedicated his life and has a very incredible team from the Netherlands that are really pushing this new healthcare data standard, solving a huge problem in healthcare that has been fixed in other industries. And it's like a curious case about why we don't have that yet in healthcare. And so we're going to be talking about different industries and also talking about what makes this an opportunity in healthcare. And so before I start, Rien, can you please tell us a little bit about Firely? And I like to start with definitions. So how do you define interoperability, and what is your guys' mission right now?
Okay, so first of all, a little bit about Firely, maybe. So we're a software company. We're based in Amsterdam, the Netherlands, and we've dedicated our let's say the existence of our company to the cause of FHIR, FHIR, although our name is Firely, FIRELY. And we'll talk more about FHIR later on, but we're a software company and we're in the health interoperability space, meaning that we build software that enables data exchange in healthcare. We're a small company, we're a startup, we were founded in 2015. And we have our clients are mainly in North America and Europe, especially in countries that have adopted this FHIR standard for interoperability. We're a technical company, software developers mainly, and I'm happy to be the CEO and founder of the company.
And it's quite a team that's very inspiring. Also has one of the actual founders and creators of FHIR. And you guys do consulting services, but also run the premier FHIR event of the world called Dev Days coming up in 3 days. So we'll also definitely want to talk about that very soon. But I encourage everyone that is, especially if on the technical side, if you're on the back end or if you are a developer, even if you are a digital health entrepreneur, you want your team to understand more about FHIR. We're talking about how this year is different, of course, because it's a virtual edition, and you'll get to know more about it. Really quickly, I just want to give a shout out. Of course, we're Health 2.0 Egypt. We're the official chapter of Health 2.0. We are partnered up with T20, a network of change makers in Egypt that have been helping us spread the word. And also special thanks to Eva Pharma for providing this platform. The reason why this webinar has been important is, there's a lot of talk about whether this is a black swan event. So is COVID-19 something that we haven't expected to happen, but is actually changing a lot of things, including how we interact in events. And really the core of this is to co-create. So we're going to give you some time in the end to ask questions. But if you guys have any questions that pop up, please use the Q&A button and not the chat. So when you post something in the Q&A, Rien and I will be able to see it, and I'll make sure I ask him as many questions as possible. Lego is something, so this slide, I've had it for all of my webinars so far, but Lego specifically and co-creation is a huge part of interoperability and how people can create together. And so we're gonna start, and Rien, I'm going to give you show you an image and ask you a question, if that's okay with you. And I'd like to get your feedback on that. That's how we're gonna structure it. So we're gonna do that for about 45 minutes and then give people some time to ask. So are you ready for my first throw?
Absolutely.
So this first, it's more than an image, it's a GIF, but we've all been following SpaceX, of course, recently, and being able to put two people in space, take them all the way to the International Space Station at a fraction of the cost that we used to do. And so I've been looking at the International Space Station, and I found this video of how it is built from components that we have, as human beings, hurled into space from 5 different countries that have devised these components, mostly from Russia and the US. People, 2 countries that don't normally like to collaborate, but they've been able to do that in space through these adapters. And I found that metaphor to be very relevant to interoperability. So my first question to you is like, how come we're able to do that at such a sophisticated level in outer space, and not being able to do that in healthcare? So, you know, this idea of hospitals speaking to each other and building things together. Where are we when it comes to interoperability in healthcare, and what are you seeing now as trends?
Well, I like that picture, Omar. Well, first of all, well, I think they have the brightest minds in aerospace, right? And maybe that's it. But I'm not an expert, of course, in that field. But well, you know, you have to. I think you have to keep in mind that space travel has always been something that has captured the imagination of people. You know, it started with the Apollo mission with the man on the moon, and you know, that really captured the imagination of a lot of people. I think that's very important, and I think 10,000s of people have worked for a decade or so to work towards that single, very pinpointed goal, right? Putting a man on the moon.
Yeah.
And that's, I think it's amazing what people can do if they have this one single goal that they all adhere to. Now, when you compare this this single goal of putting a man on the moon, and you can succeed or you can fail, right? You do it or you don't. Mm-hmm. But in interoperability, it's a different beast. It's not a single goal. It's diffuse. It is a different kind of goal, and it's not a matter of you succeed or you fail. It's a matter of more or less. So that's one huge difference here between the spacecrafts or the launch of a missile like we saw with the SpaceX. Interoperability, if I for instance, if I send you a PDF, or the lab sends a PDF with a lab result to the GP, to the doctor, and the doctor is able to you know, click on the PDF, and here's the PDF with the lab result. Mm-hmm. Now, that's not much of interoperability, right? You would expect the lab result to end up in the patient file. I mean, the single data. But it's not a lot of interoperability, but it's more interoperability than, for instance, the fax, the lab result coming in through the fax. So that's a huge difference between, I think, the launch of a missile or the single goal. And the other important thing I think to take into account is that when you have the launch of the SpaceX missile that I think Elon Musk has been working on for maybe 10 years, I don't know, that this is a single company with a single goal. Whereas if you look at interoperability, you have all these stakeholders. You have the doctor, the nurse, the medical specialist, you have the patient, you have the family caregiver. There's all different stakeholders across different organizations with different interests, different financial interests. Think about the payer as well, you know, and all these stakeholders have different interests, very unlike the SpaceX mission, a single mission, a single goal. So that makes it very different as well, and maybe more difficult to achieve actually when you look at interoperability and compare it to the space mission. Mm-hmm. So and there's another. If I just interrupt me, Omar, if you want to interject a question.
Well, I think that's a very interesting point that you raise up, and that's actually a great segue to my next picture. But from my work with payers, and most of my work in interoperability has been with big insurance companies in the States, and there is this blatant like misalignment of incentives, right, between different EMR companies. Payers, doctors want something completely different, And insurance companies have actually been paying health information exchanges and doctors to give them better data. But being an analyst on the other side of that data, a lot of the times you can't even tell which doctor wrote which lab, so you can't analyze it. And so my next question is around, or my next picture is, bringing it back to healthcare. We all know these pairs. So, one of the biggest thing that especially, the US has seen, and we're seeing more and more around the world, but it's like the digitalization through electronic medical records. And I assume those are a big part of your concern and work with Firely. We're hearing a lot of these medical records now that are the holders of our data, being open and implementing FHIR. And we're going to talk about what FHIR is exactly, but implementing interoperability or talking about it. But at the same time, we're hearing in the news the Epic CEO saying that they're not going to make data available, and then at the same time, we're seeing CMS come up with interoperability rules and doctors being kind of listed or shamed to if they're not sharing data. And it's a very sensitive issue, of course, because of privacy and stuff. But when it comes to these electronic medical records, what is the history there, and what are you seeing them do in terms of aligning on a single goal, kind of like the space mission? Are we getting close, or are we far?
Well, discussions about interoperability often become vendor bashing, right? And we all know these stories about the vendors sitting on their or your data, and it being very difficult to get to your data. Well, I don't think you can say that the vendors are anti-interoperability per se. And if you look at the FHIR community and the people that we work with and the people who attend the HL7 working group meetings, where actually this whole idea of data exchange and opening up data silos is being made, this is where you find a lot of bright minds from the vendors, people who care about interoperability and care about collaborating in a non-competitive way. And you see that happening at Dev Days as well, with speakers from the different vendors who have a common goal. I know the stories about the Epic CEO as well, and they're famous, of course. But it differs per vendor, I guess. And what I see as a more persistent problem is that is who should be paying for interoperability. So the vendor, if you sell an EMR, an electronic medical record piece of software, as a vendor, you might argue that interoperability is a feature. And the customer should pay for the feature, right? Because that's the game. But on the other hand, the hospital might say, well, what good is this piece of software if I cannot get to my data? That's vendor lock-in, And you might even argue that the ultimate beneficiary of interoperability is, of course, the patient, right? So should the patient pay? So the whole problem is around who should pay for interoperability. And if you all have a problem, the same problem, then what happens, right? No one feels responsible for the problem. And I think that's a dilemma for interoperability. It's in between stakeholders, so no one feels responsible and no one's willing to pay for it. And I guess that's where the government steps in, like what's currently happening in the US with the 21st Century Cures Act, but also happening in different countries in Europe where the government steps in and mandates interoperability. But for the government, it's not that easy either, because many governments have had, well, let's say, mixed experiences with interoperability in healthcare, where they've spent billions of dollars that ultimately went down the drain. So it's a difficult problem because it doesn't really belong to anyone. That's something that I see happening.
And do you see this happening in like certain countries better than others? So I hear about the experience in a lot of the Scandinavian countries, specifically Norway, with this. They have this EMR called DIPS, and
Yes,
essentially
yeah.
every Norwegian hospital is using DIPS, and so they have a de facto interoperability. Now that's not essentially how the capitalist system works, but it's a government-run EMR. That's the only company that does it, and we can argue whether capitalism works even in healthcare at large or not. But the fact is that they do have interoperability, just because, but they don't have maybe like they don't have competition, and therefore their EMRs aren't necessarily as fancy as Cerner or Epic, but they can share data. So which one is more important at the end of the day? Is interoperability worth taking a little bit of innovation out of the products and making sure we share it? It's a difficult question, but do you have any thoughts on that?
Well, I don't think DIPS is a government-run business. It's a business, a commercial enterprise. And if you look at the famous example, which was in the UK, where a project by the NHS to build such a government-run EMR, they failed miserably, and so it's building software is not something that the government is good at. So I wouldn't be a proponent of that scenario. And the funny thing is, Omar, in when I speak to people, especially, by the way, the Americans, but also the Norwegians, it always seems like people think that it's better in another country, and people within 5 minutes they start complaining about their own healthcare system or their own health IT. It's always better elsewhere. And then when you talk to these people who are elsewhere, they have the same complaints. So if you talk to the Norwegians about their interoperability, you will hear a lot of stories of things that are going very, very slow. And that even between hospitals that have the same EMR, it's hard to achieve interoperability. That happens with different hospitals who have the same, for instance, Epic EMR. It's not that easy to exchange data if you've implemented the EMR differently. So,
yeah, absolutely. I heard you can have like thousands of implementations of Epic.
Yeah, correct. Yeah, so I'm not sure if that, and even if you could technically, the question is if you can do it functionally, because the workflows might be different, or there might be policies or security or privacy restrictions that are still barriers to data exchange. So I think it's well, it's not. I think the story is of proceeding slowly, but it's not a success story all the way, like in other industries, probably. But hey, maybe that's because I'm not in those industries. We don't see the struggle there.
Yeah. I guess the summary of this point is that the grass is always greener on the other side, right?
Yeah. Right. Yeah.
So we have a question from engineer Mohammed Noor. I think it's relevant to this point, so I'll ask you to comment on it before we move on to the next one. But and engineer Mohammed Noor, by the way, is a digital health correspondent of WHO in Egypt. Someone who's been involved with and always has some interesting questions. And he's asking about. Can you clarify about? You just mentioned that there was a lot of money invested in by governments and went in vain. So he's asking for clarification on that.
Yeah. So the one that I was referring to is the famous NHS project that targeted on a single EMR for the entire UK. But if you although maybe that's not even a good example, but take another example is meaningful use in the US. You may probably have heard, which was part of Obamacare, the incentive to digitize healthcare, which in a way was a huge success because it um, so currently I'm not sure about the exact numbers, but when it started, everything was paper. But it digitized most of the hospitals in the U.S. Obamacare, meaningful use, the incentives there. But in the end, Congress noticed that it didn't really achieve interoperability. So everyone had their EMR, but it still was impossible to exchange data. So if you, as a patient, would move from hospital A in city B to hospital D in city C, you couldn't get your file, which was very frustrating, because they spent, I think, $30 billion or something in those incentives. And in the end, now what you're seeing now with the ONC final rule, the 21st Century Act, is in fact, I think, a way to repair that omission.
You gave me another great segue for my next picture.
Okay, great.
I'm not able to surprise you at all in this webinar so far. So my next one is well, I'll describe it, but then I want to ask people a poll. But my next picture is something that we might consider ancient technology, but is worth talking about. I remember the very first time my dad parked the car as a kid and watching him go, speak to a machine in the wall and come back with money, and I was like, wow. And so this makes me think of interoperability too. This to me is like the best example of interoperability, right? We have financial data that is owned by a certain bank, but it really is like I do feel an ATM makes me feel like I own my account. Now, this technology may make us feel happy or sad depending on what number we see in there. But this idea that I can go to any ATM in Egypt, regardless of who I'm banking with, and get some money. And of course, okay, if it's not my bank, then I pay a fee. But also when I come and visit you in Amsterdam, I can use an ATM in Amsterdam and get that data. And I really want to ask you, how since you're like integrated with that work, how far away are we of having a similar thing for healthcare, where I go to in a pharmacy or in a clinic and I immediately pull my clinical records, pull my labs, and give them to the doctor. And while I have you think of that, I want to launch our second poll real quick, just to get a feel of where people. What people think of when, and this is to the audience. So if you're not looking at your screen, please let us know what you think about your own healthcare data. Now, this question is specifically about healthcare data, right? So do you feel that you have ownership on your own healthcare data? And Rien, before we go into like the actual question, like how about you tell us your answer to that poll. Do you feel like you own your own healthcare data in any way in the Netherlands?
Well, no, well, partly. There you go. I don't own it. I can view the data that is shared by my hospital, although I must admit that I rarely do. Yeah, I can. My hospital is an Epic hospital. And I think I have my chart, so I can log into my file, and I can retrieve a lot of data, actually. Really? That doesn't mean I own it. I'm not sure if I would want to own my health data. It's entirely different, by the way, than the data that I own, which is more like wellness data that I own on my phone, right? My steps and heartbeat, etc. That's a different story. But my medical record, I don't own it.
It seems like, most people feel the same way. We have a whooping 76% of people don't think that they own that data.
Yeah, and, it's a pity. You should ask a second question. Is it a bad thing? Are you, does it bother you?
Well, I mean, from let's think about the positive aspect of it. If you do own that data, then and at least when I'm asking that question, I'm thinking when I go to a doctor, or when I have done, let's say surgery 5 years ago, and I'm seeing a primary care doc, I do want him to know, or her to see my labs, at least like the past couple of months if I have done them. And another positive aspect is that I don't have to pay for multiple things, right? In the US, like 1 out of every 3 Medicare beneficiaries have a CT scan, for example. Whether they need it or not, I might have done a CT scan 2 weeks ago, but now I'm in a different state and different hospital, and they're like, whoop, we're going to test you again. So it does save money, I think, to own the data, even if you're not monetizing it per se. But I'm back to my ATM analogy. Like, do you think we're getting closer to there? Like, and it's hard to ask you that question because you might be biased because that's what you do on a daily basis. But have you seen much progress since you went into the market until now? Is it hopeful?
Yeah, there is progress, but it's very slow. But you have to keep in mind that in healthcare everything's very slow, and that's not a reproach. It's happily so, because it's healthcare is, it's in the end it's about your health, and it's a matter of life and death. So it tends to be a conservative industry, and it is so in principle and by nature. So I know there's a lot of entrepreneurs here in the audience. So being a startup in healthcare it takes a lot of patience. It's so if your horizon is 3 to 5 years to achieve your goal in healthcare, being an innovative startup, that's pretty ambitious. Because in healthcare, everything goes at a slow pace, and so is interoperability. So do we make progress? Yes, we do. And I think that FHIR is very important to the progress that we are making. But even with FHIR, which is the best we've had so far in healthcare, I'm convinced. But even so, it will take a lot of time to achieve a higher level of interoperability. Also, like I mentioned before, it's not a thing that you can achieve for the full 100%. It's a more or less thing. You can have more or you can have less, but you can't have it all. And we don't need to have it all.
Yeah, I like.
Maybe Omar, that's the difference between the ATM. If you look at what you can do at the ATM machine, you can probably see how much money you have and then retrieve some of it. Yeah, that's about it.
Yeah.
And that's about it what you want. You don't want any more, probably.
Yeah.
So the use case is fairly simple, but even so, I think, although I'm not in that industry and I'm not an expert and I don't know anything about it, but I think it's my gut feeling that it's been a huge effort to achieve even that goal of having that ATM machine in another country being able to give you money because you have it on your bank account in your home country. So a lot of people involved, a lot of standards, groups, committees, probably regulators, the works.
Yeah.
And what can you do? You can do two things. You can retrieve money and see how much money you have.
And yet, if we think about it, all this effort or all this progress has been happening in the finance industry. But I can plan for a trip. If I'm traveling to Amsterdam, I can plan to have enough cash or to have a transfer to a friend or something. But when it comes to like healthcare incidents, most of them are God forbid, emergencies or things that you can't really plan for. So it's interesting, again, like the access we have to our bank accounts and the lack of access that we have to medical records. And Mario just kind of gave a very interesting opinion. Like maybe the poll should say, do you have access to the data rather than do you feel like you own it? And access is like, yeah, I think spot on, Mario. We do have a couple of questions, but I wanna move on to the next thing because we're halfway This like 30 minutes past flew by. But we haven't started talking about fire yet. So I do want to just get into that, and really quickly, for those of you who don't know HL7 is the international body that's organizing healthcare data and attempting to standardize it, and it goes back to the 70s. Maybe not HL7, but the idea of creating standards. And this slide has a lot of things, but really, there's what I want you to remember is that there fire is like the fourth iteration of that. And this is what version 3 looked like. From my experience, half of the hospitals are on version 2, which is a very simple message being sent from one doctor to the other. And then when they came to version 3, they decided to create this thing called reference information model, which you see now is not simple. It's not simple at all, actually. Try to basically represent the whole experience of a hospital. And so what we started seeing in at least in US hospitals is that each hospital has its own reference information model, which of course defies the point completely. And then enter FHIR now. FHIR is the latest standard, and it's I think the main premise, Rien, is this idea of FHIR being simple, right? And FHIR being this is the graphic that the designers did for us. It's like FHIR being, I like to think of it again as like Lego blocks, right? Like I had I was a Lego addict when I was a kid. So maybe it's my bias, but this idea that, FHIR is based on resources that I can only send you this resource called patient or observation or clinician, provider. And like these resources are all you need. So it's like boiling it down to kind of like the most common 80% rather than trying to get to like the obscure 20%. But from that perspective and historical perspective, I wanted to ask you, what does FHIR, what was the impetus for FHIR, and what makes FHIR great? Like what makes us all so hopeful that this is the answer to interoperability compared to the previous standards?
Yeah. So okay, first of all, it's the best answer so far, and it's a better answer than previous answers, I guess. Although, don't forget that when you look at HL7, the most successful standard, which is still very much in place, is V2. Mm-hmm. So that's the version 2 standard, which was like sort of an EDI-like standard. But the nice thing about FHIR is that it's bringing something to healthcare that's been very successful in other industries, and that is the API. Mm-hmm. More specifically, what we call the RESTful API, the REST API, which is technology. And I don't want to go into the technology, but what you have to keep in mind is, I guess, that the API. Well. You remember, maybe some of the of the people in the audience may remember that back in the day when we had the first versions of the World Wide Web, when you had this amazing thing where you had web pages, and in a web page you have a link, and you click on the link, and what happens? Another web page appears. And this web page, it might be on another machine in a different country, created by a different person. And the whole meaning of it is that because on that web page, you also have a link, a hyperlink, remember? And you can click on that link. We're totally used to this mechanism, but back in the day, it was a miracle that you have all these pieces of information who were interconnected. And I think the foundation of the internet and the language that was common for the World Wide Web to happen was HTML, right? So all these documents with the links connected the HTML pages. Now, and I think the API, the REST API, uses the same foundation that the internet is built on, not to connect documents, but to connect actual software systems, to connect databases. Yeah. And that's what the API is really doing. So the amazing thing is that you now have databases across the World Wide Web, across the internet, databases, software systems that can actually connect through these APIs. And that's a technical trick. You don't need to know the mechanics of the API, the RESTful API, but the economic importance is that you all of a sudden have computer systems talking to each other, that you have apps being able to retrieve data from software systems, which is what happens if you, for instance, I always like to use the example of Google Maps. Now, Google Maps has an API, you don't know about it, but it's being used all over the world in millions of apps just to retrieve data about a location. And that's the API. And look at what it's done. It's enabled, for instance, food delivery, right? There's a whole new branch of companies, a new industry that evolved around the concept of APIs. And this has been going on in all sorts of industries. And now FHIR has brought this concept of the API, of interconnecting systems, like the system of the pharmacy, the system of the GP, the hospital, the lab, the app. Here, the app, the patient app, connects all these systems through APIs so they can communicate. And that's, I think, the major achievement is that FHIR has brought this existing technology, which is the RESTful API, to healthcare.
Another thing that I really like about the technology behind it is the Smart on Fire platform, right? I don't know if platform is the right word for it, but essentially the ability to connect to these mobile apps instantly, and it really is, I think, the first standard that encourages mobile applications and innovation outside it. Like it's built for a very new and modern technology stack, unlike those before it. And have you been seeing a lot of people kind of leverage Smart on Fire, or is it still in like theoretical phase, and especially when it comes to aggregating all that data to like population health dashboards and stuff like that? Are you seeing it like being used regularly?
Depends on the country. I think, for instance, here in the Netherlands or in, I think in Northwestern Europe in general, it's not happening a lot yet. But if you look at the US, it's really going, you see real examples there happening, and their apps are being built that use these protocols that you just mentioned. And the secret here is, and I think if there's a lot of entrepreneurs here listening to this interview, the nice thing is that FHIR or Smart on Fire, let's put them all together, and let's say FHIR enables these entrepreneurial ideas to be realized, because now you can all of a sudden, you can think of an app that does this magic, this one little magic trick in that really eases the life of the doctor or the patient. And you can build that app and launch that app, use that app with the data that sits in the EMR. And those things weren't possible before FHIR because you couldn't get to the data in an easy way. And the API, the FHIR API, allows you to retrieve that data and to actually build that app and put it in the hand of the doctor or the nurse or the patient. So I expect a lot of innovation happening when the entrepreneurs, the startups, start thinking of, oh, hey, now that I can get to the data, what can I actually do to it? I think similar things are happening in fintech, where you now have here in Europe, I think, I'm not sure, it's probably popular in Egypt as well. But now you have this PSD2 initiative here in Europe that says that's all about open banking. So your financial data, if you allow a third-party app to get access to your data, then that third-party app could be anything. Could be your household budget booklet or whatever, So there's a whole range of apps now who come into existence because banks are opening up their financial data And one example here in the Netherlands, which is extremely popular, is called Tiki, which is an app which is basically it's a payment request through WhatsApp. So I can send you a WhatsApp message with a link and say €6. Please pay me €6 because of we had a drink, whatever. And then you click the link, you're directed to your bank app, and the money is transferred to my account with just 2 or 3 clicks and one code that identifies me. So you see the same mechanism happening in other industries as well. And we'll see similar things like the Smart on Fire apps happening in healthcare. And I think that the imagination of the entrepreneurs who think about these apps and who think about, but this is how I can make a company, that will spark innovation.
Absolutely. And I like how you balance that with earlier talking about how it's really hard to build a digital health company. Like I haven't spoken, and I've interviewed many entrepreneurs, and in like the 7 or so years I've been in the industry, no one in healthcare has said, it's easy. Like everyone finds it incredibly challenging, and it's really refreshing to be seeing like technology such as these actually spark innovation rather than be an obstacle to it. Because everything else is an obstacle. Everything else seems to be a challenge, and you're gonna hit a wall.
Yeah, if you like innovation the hard way, then please join us in healthcare.
So speaking of that, it's time a little bit of a shameless promotion. And this picture is of Dev Days, the event it's the premier Fire event that is also run by you guys and Firely. It's been growing steadily now. This is a picture from 2018 in Boston, and I believe the next one is coming up in 3 days. It's the event to be there if you are a developer or an entrepreneur that wants to be there. Actually, I want to ask you about this event, but it's worth noting that it's virtual this year, and it's happening in 3 days. I'm honored to be moderating a few sessions in it, so I'm really excited for it, and wondering what's in store, who should go to Dev Days, and how do they go there?
Yeah, so Dev Days is an educational event. We always like to say that it has 3 pillars, which is to learn, to code, and to share. So it's I think the main audience here would be technical people, like for instance developers in health IT, or CTOs, product managers. We also have startups building apps. It's a technical event. It's a real tech event. And this is where you go to learn about fire because of the education, all the tutorials, the workshops. There's over 100 speakers, but you will also meet people. There's a lot of networking going on, even during the virtual event, and it's where you also have the opportunity to meet with the industry. So who's attending? It's the major players, the large health systems, the major vendors are there, but also big tech joined the fire community. So Microsoft, Apple, Google, Amazon, IBM, they're all there showing what they have to offer in the fire space. And this year, what's also special is that there's a lot of focus on the new regulation in the US, the 21st Century Act that I just mentioned, which will make fire kind of mandatory for healthcare, for the healthcare industry.
Mm-hmm.
Yeah.
Awesome. And how do people go and sign up? And it's also like it's a special year because you don't have to travel anywhere, right?
Yeah. So this was Boston, 2018. Last year we were at the Microsoft campus in Redmond. And this year we should have been in Cleveland, Ohio, but well, of course, because of COVID-19, now it's a virtual event, and it will run from Monday to Thursday next week, 1 to 5 or 11 a.m. to 5 p.m. Eastern time. So that's just doable for our time zone. And if you go to the website devdays.com, you will find the schedule, the speakers gallery, and the registration page. And registration is still open, and I expect people to register over the weekend, because now it's so easy. You don't need to book a flight. You don't need to make a reservation in a hotel. It's just you can stay at home like what we're currently doing.
Yeah, and it's also at a fraction of its cost. So I just sent the website. Definitely highly recommend this event, and especially for those of you leading digital transformations and working with hospitals here. The more that these people know about FHIR and understand FHIR and are able to communicate it, I think there's a huge opportunity. Yeah. And also, Rien has a very entertaining video that they can probably see it on what your
if you go
LinkedIn,
to the well, we have a Dev Days channel on YouTube. If you search Dev Days on YouTube, you will find an instruction on how to build this virtual real thing.
Yeah. It's I'm definitely working on my Dev Days one for Dev Days, but also want to start building ones for Health 2.0.
Yeah, you should.
And we have a lot of questions. It's a very sophisticated piece of innovation, I think.
This is high tech.
We were discussing before we started raising some funds for this. I think in this virtual world, there's going to be a lot of utility for things on screen. So yeah, definitely check that out. Also, before we get into the questions, and there seems to be a lot of them, so I just want to check with you, Rien, if you're okay if we stay like a few minutes over, maybe 5 or so. But if not, we can end promptly at 9. There are a few questions, so I want to invite you to look at them too and see if there's a specific thing. I see a lot of questions, and I'll just ask the first one here. If there's a lot of praise for you I'm seeing, and things that I'll send you. But like one question is how do governments, again, we talked a little bit about this, but is this a best practice that healthcare entities can choose to follow, or should it be should governments really be obligated or obligate hospitals to use it, in your opinion? And another question again we had from engineer Muhammad Noor earlier is, can the government just decide to start its own standard? Like what if the government of Egypt decides to do something that makes sense to it rather than HL7? So the question is, should the government stick to HL7, and should they enforce it on hospitals?
Okay, so there's two questions here. So first of all, should it be law or enforced? And the second question is, what do I think about how do I feel about this? So should it be enforced? Well, my personal take on this is, and I've always been happy that FHIR started out not as a government initiative. It was purely an industry initiative, and it got popular because the developers liked the technology. They liked the RESTful APIs because that's what the kids learn on school, in the universities. They learn how to develop apps using those RESTful APIs. They know the technology, they like the technology. And in healthcare, developers were used to, having to use legacy development tools. And FHIR is a modern approach, and that's why the developers liked the technology, and that's why it got popular. And I like that more as an incentive than it being enforced, because there's always a lot of, if you have to do it, you don't like it, right?
Yeah.
So now what you see is that after, I think, 6 or 7 years, governments start to discover the huge benefits of fire for cost saving, for patient safety, etc. So now they are thinking about enforcing it or stimulating it, or, it differs a little bit. In the US, it's going to be law. Here in the Netherlands, it's more like facilitating by the government. And I prefer it to be popular with the developers as the key to the success, rather than law enforcement. So does that answer the question?
Yeah, it does. It's certainly a
Yeah.
bit of a
Sorry.
twist.
There was Omar. There was another question. Can you, as a country, build your own proprietary standards to? Well, you can. You will fail. Yeah. Why would you? Why would you reinvent the wheel? I'm not sure if this is. Well, it's. I certainly would, if I were a government advisor, which I am not. I would certainly advise against it, because you can throw a lot of money at it, and maybe even regulation, but in the end, if no one likes it, and everyone thinks that, well, why are we doing this, then you will fail.
Yeah. And there's another question that might actually it doesn't really challenge you on that, but it's an interesting point and might be one of the reasons why a government might want to do a proprietary thing. And so Stephen is asking, what are the translation possibilities for the standard? And is there anything being developed, particularly in Arabic, right? And he suggests that maybe that can be potentially funded by richer countries like Saudi Arabia, Qatar, UAE, to actually do a lot of that translation.
Well, that's a very good question. The fire standard itself, so for instance, the resources are all in English, but fire does not say anything about the language that the UI shows you. So you could have an app in Arab or Chinese or whatever, or the Karelian, in Russian. Fire does allow for that, but the under the hood, the resources, like programming languages, by the way, they're all in English.
Okay.
Yeah. So that's about the languages, but so I wouldn't.
But is there an effort required to translate it?
Well, for the developer would just use the resources like they are defined by the fire spec. But the user, so the doctor or the nurse or the patient or whoever, would know nothing about it. This is all under the hood. You don't see it. This is for the developer. So the user interface is kind of have any language you like. Fire doesn't say anything about this.
So we have another interesting comment again from Engineer Muhammad Noor. It seems like this topic is close to his heart. He mentions that Estonia might have developed their own standard. I don't know if you've heard of this, Rien. Have you heard of Estonia? We can also invite Engineer Muhammad Noor to join us.
Estonia was one of the early adopters for fire.
Oh, really?
Okay. Yeah, they were one of the first. Yeah, even when we were still in draft mode. I'm not sure where they are now, but so I'm not sure what what's being referred to here. I don't think so, but maybe I'm mistaken, or this is something that I know about. But
Yeah, I'd love to invite actually Engineer Mohammed Noor to tell us more about this. But while he prepares himself, I'll throw just a couple of. So there's also a comment from Samir Tedros, who seems to be um, very technical and seems to be experienced with this. He says that applications can be in any language and nomenclature, and he uses like the experience the SNOMED standard, which is a very popular one, or and he says it's available in Arabic. So thank you, Samir.
Yeah,
Um,
correct.
but a question from Sami Sharif. He says, going back to the point of who should pay for interoperability, understands the efficiencies in the healthcare systems and what interoperability can save for the patients, insurance companies, and such. Always goes back to what is in it for me, and how would interoperability really help healthcare providers. As you know, they have targets and generate profits. Thus, they want that extra scan or extra consultation. So interoperability can help healthcare providers, and I want that like a little bit to just modify this a little bit, that there's a difference also between the incentives of the healthcare systems and the healthcare providers. And the healthcare provider is really incentivized by providing better care. I don't think providers, being one of them, or at least a former one, are business people. So I don't think providers are always, at least not primarily, thinking of that extra scan. They are forced to by healthcare systems, but that's, I think, a great incentives for healthcare systems. If you can, if interoperability will allow
Well,
you to get more business.
well, the question here from is that Sami?
Sami Sharif, yeah.
Yeah, Sami's question is relevant because you know a supply-based healthcare system does generate more cost than is absolutely necessary, and that's why around the world healthcare systems are now looking at outcome-based um, payment schedules. So where you don't pay for the number of treatments that you do, but where you're paid for the healthcare benefits that you are able to provide. And actually, for this to happen, fire is extremely important because you need to have data to actually measure the outcome. So I think this is a good point, and it's being recognized by a lot of people in governments and health systems around the world that we need a change in funding of healthcare to improve healthcare.
Yeah, I
So
agree. And now,
thank you for
like,
the question.
yeah, with the especially in America, we're talking about like these MIPS incentives and stuff. Again, like healthcare systems are the ones that want to do it, but I think building on that question, like providers also want the story, like they want the patient narrative, even if their incentive is to provide better care. They really care about that, and knowing that. So we'll take another question, and there is a question from Basant asking how do we minimize the disparities between countries when it comes to AI? And I believe FIRE is the precursor to AI and interoperability. But how do we move forward with EMRs in developing countries where it isn't yet implemented? And Basant says, unfortunately, but my opinion is that it's kind of a fortunate thing, because when we look at the states, we look at it as a good example, but it's actually like a really bad example, right, of interoperability, because we've put a lot of like technology in place, but didn't really figure out this interoperability first. So, to rephrase Basant's question, for a country like Egypt with 9%, I think, penetration rate for EMRs, we're still in the very early stages. Do we have an opportunity to do things differently?
Yeah, so it's you don't have the legacy, so you can do it right the
Exactly.
first time. Yeah. Yeah.
How would we go about that, though? Like, do you create, a task force? Because we're also, a lot of these hospitals, even the 9%, are buying technology from outside of Egypt. So it's not like you can control that too. Like the biggest hospital chain has an EMR from Tunisia. So it's like, how do you do that? Like, how do you learn from other countries in Africa and in the Middle East to be able to actually, you don't have to like reinvent the wheel, like you said. So yeah, you'll use HL7, but also how do you make sure that you get it right from the first time? Like what,
Yeah,
what
that's
models or what
yeah, and
lessons?
I wish I knew, Omar, but I think that the opportunity to learn about what's going on in other countries is now bigger than it's ever been. Right? We're having this webinar. It's all online. We will do dev days online. There's tons of YouTube videos about fire on our dev days channel on YouTube for free. So there's a lot of opportunity to learn about other countries, far more than there were, let's say, 10 years ago. There's so much information now, and I think it all starts with information sharing, and learning from other experiences. Um, Having said that, it's that this is not an easy job, right? I mean, it's it's always kind of difficult to set it up right, even if you have a greenfield situation.
Mm-hmm.
But what I would like to see is, if you look at the so we run this platform called simplifier.net, and we see users signing up from all over the world. But we can see where fire is being adopted and where it isn't, or it isn't yet. And I think if you look at the Middle East and Africa, there's still a lot to win there, and that's what we try to achieve as the fire community. And it's also something that is high on the wish list of the fire leadership, but that'll take time.
Mm-hmm. So just a couple of things before I throw like one last question. So first of all, I have the survey is open now. So please just use your device to let us know how we did, and this is really important for us moving forward to get you the best content. We also are posting all the videos from all the webinars for free, both like short clips and long versions. So this will be recorded and posted on our YouTube channel too. So check out our YouTube channel for all this content, and also check out the Dev Days YouTube channel for more specific content about fire. And Rien, do you have time for two questions, or should we just throw one more?
Yeah, go ahead.
Yeah. Okay. So there's one that I like from Rania about providers. What is the first step that a provider can do on like a micro level to integrate digital healthcare? Do you think providers have, the responsibility, but also like can they really change things? Can providers do something on a day-to-day level to help the bigger picture of interoperability, or does it need to be like top down?
No, certainly not top down, but so suppose, I'm not sure, as a provider. So let's say, I'm not sure if Rania means a doctor, but I would suppose if this is a doctor in a certain institution, I would talk to my IT manager or CTO or CIO, and take some real concrete use case, not in general, but a real use case, like home monitoring or some sort of digitization that you think is appealing and not too hard to achieve, and discuss this use case, make it a business case, and try to see if you can have one small success that then might be an example for other people or for other initiatives.
Mm-hmm.
I wouldn't start making it too big, or making it or doing it the top down approach.
Mm-hmm.
So I like the idea of doing this bottom up, the micro level idea.
Yeah. Okay, so I have one like closing question. There are a lot of really good questions. I think Rien answered most of them. There's a question about a success story in Egypt or MENA. I don't think so, and I don't know if you heard of anything. but we certainly haven't heard of any big implementation of Fire. I know most of the executives are. Some of them know about it, but they're still trying to. Have
Well,
you?
there's some things happening in some. Well, I'm not sure. I'm not involved in this project, but we get some questions sometimes, and we have had some visitors to Dev Days as well. But I'm not aware of any Fire implementations going on in Egypt, unfortunately.
How about the UAE?
Yeah, probably yes. Yeah, and if I'm not mistaken, um, these are government initiated, but I'm not sure.
I do know that the current government, we have the universal health law coming up, and that's been the biggest effort of the Ministry of Health, and they have a team that is very aware of HL7 and Fire standards, but we've been having other obstacles for the implementation of it itself. But there was this idea for sure that the government is talking about. I know for a fact that once this universal health law is applied, or universal insurance, I mean, is applied, then they would only interact with other clinics or other hospitals that are using Fire. So
Okay.
using it as an implementation standard.
Mm.
But we can't say that it has been implemented.
Okay.
Yara Abul Wafa is saying she believes the UAE is implementing it right now, and it's truly government initiated. There are a lot of thank yous. A lot of people are thanking you for your time and for sharing all this information with us. And I wanna close with one last question. It's really hard to not mention coronavirus. So I think I want to congratulate us both for not saying COVID-19 or coronavirus so far in this whole webinar. It's impressive, I think. But it's not complete unless we mention corona. So one question I had is, how do you think in a different world where we have global interoperability, we can share data across all hospital systems and stuff.
Yeah.
How would we have dealt with this pandemic differently?
Wow. Omar, I don't know. I think what we need is a better Bluetooth standard, right?
Bluetooth standard, yeah.
Yeah, because
True.
it's all this. What's the Google Apple initiative? The tracing protocols that they've now built in, but there's a lot of doubts and skepticism about the feasibility of tracking based on Bluetooth. So maybe we need a better Bluetooth standard first. I don't know. But it's funny that you should ask this, because at Fire Dev Days next week, we have a COVID-19 track moderated and introduced by Matthew Holt, Health 2.0, by the way. So that's and one of the things we'll talk about is we have this very sort of controversial statement saying if the Fire APIs would have been ubiquitous, then fighting or tracing COVID-19 would have been easier. But I'm absolutely sure that this will be, and there's a lot of experts on that panel. People will have different opinions about this, so we'll see. It's next week on Wednesday or Tuesday. Tuesday afternoon. Yeah.
So Dev Day is going from 15th, 16th, and 17th, right?
15? No, 4. So Monday to Thursday. Yeah.
Monday to Thursday. Okay. So Monday to Thursday next week. Again, go to devdays.com. Awesome cliffhanger you left us with there, Rien. I'm certainly excited about next week, and I want to encourage again everyone to go to their YouTube channel and also go to our YouTube channel. Subscribe on both so that you can get more of this content if you like it. And Rien, thank you so much. This has been delightful talking to you. A lot of ground covered.
Omar, I want to thank you for giving me the opportunity, and I want to thank all of the people in the audience to spending their Friday evening listening to talk about health data standards, man.
That's when you know you've reached your target audience. When you do an event Friday night in Egypt.
Yeah, you're the best. Thanks.